Kia ora. Firstly, I'd like to thank Te Ateawa Taranaki Whanui for the welcome to ancestral lands, and hopefully my Scottish accent did that reasonable justice. Thank you. Really amazing to be here, really honoured to be able to speak to you all today. Thank you so much to the organisers and to New Zealand Drug Foundation for the invite to come today. As stated, I'm Kirsten Horsburgh. My background is mental health nursing and previously worked in drug treatment services and have been working at Scottish Drugs Forum for 11 years, and it just so happens that it was a coincidence that today is my first day as taking over as CEO. Scottish Drugs Forum is fairly similar to the Drug Foundation here in terms of our roles and remits. We are a drugs policy organisation. We have a number of different projects within the organisation. We have a huge range of volunteers who have their own living and lived experience who help us with peer research, and we have an addiction worker training project which aims to pay traineeships for people with lived and living experience to work in the sector. So a huge range of different work that it would be great to talk to you more about, and happy to do so later if that's something that you're particularly interested in. I was asked today to speak around the Drug Deaths Task Force and the Scottish Government's national mission on drugs, which I will do, but it's important to get some context firstly around the issues. And it strikes me from all the presentations today, which have been great, and all the discussion, that no matter where you travel to in the world, there are satisfying themes that are relevant to what I'm going to be talking about, but that are equally depressing and frustrating when we see the challenges that we all have. So firstly, I want to just talk about, in Scotland, we have the highest rates of reported drug-related deaths across the whole of Europe. Every time we talk about this, I always like to remember we're talking about individual people. Behind the statistics, we get caught up sometimes in numbers and graphs, and actually every single person who dies is somebody's son or somebody's daughter. They might be somebody's neighbour, friend, brother, sister, and certainly whenever I talk about this, I have clear visions of people in my mind who I've known who've died and sadly lost their lives at far too young an age. We have around 5.4 million people in Scotland. Around 60,000 people are experiencing drug problems. Mostly in Scotland, it's heroin and benzodiazepines that are used. We have 14 health boards across the country, and each health board has at least one alcohol and drug partnership which coordinates and commissions the services within their areas, and we have 15 prisons. And I was recently at the Harm Reduction Conference in Melbourne, and your former Prime Minister, Helen Clark, opened her speech by saying that there are 3 countries with significant drug death crises, and US, Canada and Scotland were name-checked in that opening speech, and that should be, for us, something of a significant national shame to be mentioned at such an event, having such high rates of overdoses. In 2021, which is our last year of recorded figures, we will, in the summer, have the numbers of people who died in 2022. But the previous year, we had 1,330 people lose their lives from accidental and preventable drug overdoses. These are not deaths from bloodborne viruses, bacterial infections, road traffic accidents, anything else to do with drugs. These are entirely preventable deaths, which is quite shocking. The main drugs that we see involved in overdoses are heroin, methadone, benzodiazepines, but rising numbers of cocaine being involved in the drug deaths, and alcohol in there as well. People in Scotland use multiple substances. It's very rare for it to be an individual substance that causes the death, so it wouldn't be unusual to see 5 or 6 substances being causal drugs in the death. And we wonder why we have such high rates of drug-related deaths when we have such significant issues with stigma, with marginalisation, with criminalisation, and often dehumanisation for people who've often experienced unimaginable trauma. Poverty, deprivation. In Scotland, you're 15 times more likely to die of a preventable death, a preventable overdose death, if you live in one of the most deprived areas in the country. And that's on top of people experiencing extreme issues in terms of their physical health and their mental health. So you don't have to look far to find stigma. Thankfully, in the mainstream media in Scotland, there's less so of that over recent years. But just a quick search when I was putting this presentation together, and it doesn't take much to draw out the stuff on social media, that we see frequently, and this is what people are commonly faced with. We should really be asking ourselves the question, why our health services also are part of the issue when it comes to stigma. We question people to such a degree of personal information that only seeks to exacerbate the feelings of low worth and shame that people are faced with, and we often get people to repeat this story over and over again to different people. That relationship and that trust is really hard to build. And that's across all of our health services that we witness that. We should really ask the question why people would rather experience such significant wounds because of their injecting drug use, the pain that they experience, physical pain from wounds, rather than going to a health service. And it's often not until a person is potentially likely to lose a limb from their wounds that they are likely to seek that help. And it's a sad state of affairs when we have to remind services that people who use drugs are, in fact, human beings. Our language is also important in this area, and whilst language seems like such a small thing compared to some of the major issues in terms of stigma, our language shapes how people are treated and how services respond to people. Scottish Drugs Forum created a glossary of terms just to try and support areas to look at how they use their language and what language is used, and certainly it's online for anyone to have a look at, but your words matter. In 2008, Scotland had a drug strategy named the Road to Recovery, and this strategy had a particularly damaging effect, with a focus on abstinence that really had an impact on harm reduction. It defies logic that we continue to question the effectiveness of harm reduction despite the overwhelming evidence that harm reduction works. And certainly that's something that we see frequently in terms of the harm reduction approaches being questioned. Whilst we're quite lucky in Scotland to have a range of harm reduction interventions, we have widespread needle and syringe programs, we have opiate substitution therapy, we have all sorts of, we have an naloxone program which I'm going to talk about. We don't have things such as drug checking services and drug consumption rooms. So in order for harm reduction to be effective, we need the full complement of all harm reduction efforts. We need them to be adequately resourced and implemented, and certainly we need in Scotland, definitely, to be upscaling all of the things that we're doing around harm reduction. At the Harm Reduction Conference in Melbourne, it struck me that even under the most extreme circumstances, particularly with countries that are facing significant human rights abuses, people who care are still able to provide services. And mostly that's provided by people who use drugs and peer approaches. It really highlighted for me the privileges that we have in Scotland to be able to develop our approaches, and that we're just not doing enough. And harm reduction can also only go so far when we continue to criminalise people who use drugs. We wonder why our prisons have a drug problem when we continually send people who use drugs to prison. And we also have an extremely outdated and unfit for purpose Misuse of Drugs Act. So when we don't provide harm reduction, we're essentially throwing people into the ocean without a life jacket. So this is a lane that when in our offices, when we used to all work in the office, out of my window, I used to look onto the lane in Glasgow and see this lane that was frequently used for people who were street-based injecting. And it was quite a sad state of affairs looking out of your window from a drugs policy organisation to be able to see people in the lane directly below you actually injecting drugs, and not having a space for people to actually go. I'll remember vividly this one person who walked down into the lane. It was a horrible day, typical Glaswegian weather. It was a very horrible day. And we were working in the office, and I looked out and saw this person try to get some shelter under a little bit of bit of the building next to in the lane. And he was preparing his drugs, and he used, and then he just sort of, had nowhere to go. And at the time there were lots of wooden pallets sitting in the lane, and there was a magazine lying on one of the wooden pallets that was absolutely soaking wet, and he flicked through this soaking wet magazine, and I get emotional thinking about it, because it's disgusting that we allow that to continue. We need to be providing people with dignified spaces to use their substances if that's what they're choosing to do, instead of allowing that to continue. I'm jet lagged. I'll get over it in a second. Okay. And the next thing that happened in the lane was people were using it frequently, and colleagues of mine and I were down in the lane several times to check that people were alive, which was also horrific. And then what happened was more and more people started using the lane, and they actually used these wooden pallets to create their own drug consumption room. And they created a structure in the lane that, when we're talking about peer-led solutions, people are showing us what they need and what they want right in front of our very eyes, and then the council came and cleaned up the whole lane and took it all away. But that really stuck with me, that incident. And this is what our drug consumption rooms look like in Glasgow. This was before I did a travel fellowship in 2015. So this is basically just a really common example of a place that people would go to use. It's absolutely covered in used injecting equipment, in feces, in blood, in all sorts of horrible things. And of course, as you can imagine, when people are unable to get sterile injecting equipment, often people will go to these places to find used needles so that they can use. So in 2015, there was an HIV outbreak in Glasgow city centre, and the main driver for that was the sharing of injecting equipment among people who were using mostly cocaine, but also heroin, so the frequency of injecting was increased. And it was from that point that Glasgow was described as having probably one of the most compelling cases in Europe for a drug consumption room. Around 500 people inject in these types of environments in the city, and it prompted this report that was a health needs assessment looking at the needs for people who are injecting in public places. And it came up with a variety of recommendations, and two of the newest services that it recommended were drug consumption rooms and heroin-assisted treatment. Thankfully, we were able to start up a small heroin-assisted treatment project, but it remains the only area in Scotland that is providing that. There seems to be a lack of clinical will to deliver it, but also this lack of funding in order to be able to deliver it as well. So it's certainly a huge issue that we don't have enough choice for people. But the drug consumption room issue then became a real political football. We have quite a unique situation in Scotland where we have a Lord Advocate who's our chief legal officer for Scotland. And we, Scottish Drugs Forum as an organisation, firmly believe that the Lord Advocate could put in place a prosecution waiver to allow these facilities to be delivered instead of having to go through the UK government for a change to the Misuse of Drugs Act. It's now become stuck in this sort of political sludge where we know we need the services. The Scottish Government are supportive of us now, and I say now because once it was deemed impossible by the UK Government, the Scottish Government then were very vocal in their support for it, but I'm also aware I'm being recorded. So it now got stuck in this sort of, political sludge where Scotland wants it, England's saying we can't have it, and now it's become a real constitutional issue as well. So yeah, very, very frustrating that that's an evidence-based health service and basically a dignified service that we could be providing for people that doesn't currently exist. Obviously, they've been around for years. They've been around since the 80s. We absolutely need these services wherever people are using in public spaces or street-based injecting. We need to have safer injecting facilities. I've been to visit these facilities all over the world, and probably the standout area for me was Barcelona because of the range of different types of drug consumption rooms that were available there in terms of mobile units, fixed services, not too clinical services, but also just that acceptance that if there was a space where people might use drugs, there was also a room potentially where they could go within that facility to use those drugs. So it was just normalised, and I would like to see us get to a position where we have that as well. And then we had this, which was a concerned citizen actually just going out and delivering a van, which was delivered in the city centre of Glasgow, to show that actually there was a need for these services, that people would use them, and that he was risking basically his own liberty to deliver that, which is admirable, but is also quite shocking that this is how we think it's okay to deliver services, trying to fight for services that we know are actually absolutely needed. So the only question that I guess I would ask whenever I'm talking about drug consumption rooms is, would you, if you had a family member who was injecting drugs, would you prefer that they were in the lane or in one of those environments that I showed you in the previous slide, or would you prefer that they were in a place that people cared about them and that was dignified and they were met without judgment? And that's all the question that you need to ask. So we have a world-leading naloxone program. So we have a take-home naloxone program that we've had since 2011. We have 2 products that we provide. We've provided well over 100,000 naloxone kits to people at risk of overdose and people likely to witness an overdose. Thank you. Something that we're really proud of in Scotland. We have around 1,000 uses reported by lay people every year. That's a completely underreported figure. The number will be much higher. The ambulance service in Scotland administers naloxone about 5,000 times a year to people, which is quite a shocking thought in itself. Obviously, we would prefer people weren't overdosing in the first place. But when they do, it's essential that we have naloxone available, particularly when the majority of our overdose deaths involve opiates. We have really extensive distribution via drug services, pharmacies, via the ambulance service. They also provide it to people as a take-home product. We have a really great click and deliver service, so you can order naloxone discreetly online. It will be sent to you in the post. We have peer-led programs. We pay peers to distribute naloxone, and we have an excellent example of peer-led work in the prisons where people in prison are distributing naloxone, the intranasal version, the day before people's release. So we really see the impact of staff approaching people in the prison and them declining naloxone, and then the peers going in and completely shaking that up and being able to supply people no problem. The priority for the programme is always about supplying people who use drugs as a first priority. But we also want to encourage the general population to be carrying it just in case. You just never know when you might come across somebody who's overdosed and be in a position where you can help. This was a big campaign that we provided across the country. We won an award for this campaign. We had radio, TV ads, we had billboards, we had this on the side of buses, just to really encourage people to know more about how to recognise an overdose, but also to carry naloxone, and we directed them to the click and deliver service. And the percentage of distribution through the click and deliver service increased by about 300% because of that campaign. We also provide all of our police with naloxone. That was a massive achievement. We spent 10 years persuading them that it was probably the right thing to do because they were quite often the first responders at overdoses, and they've used naloxone over 200 times now to potentially save people's lives. We also have agreement from the Scottish Fire and Rescue Service that they will also carry it, and then they're in the process of training all their staff at the moment. So I'd just like to ask if you could just show me your naloxone kit that you're carrying today. If you could just hold it up, anyone that has naloxone. There's some people rumbling about in bags. I can see one. Ouch. 2. You might not want to overdose in this room anytime soon. Feel like a slight hypocrite because my naloxone, which I carry with me everywhere I go, is lost in transit somewhere between Edinburgh and Wellington in my luggage, which is also not here, don't get me started. So, yeah, I think it just goes to show how we need to normalise that. Although opiates might not be the significant driver for overdose deaths wherever you are, they're a combining factor. So if somebody's using multiple substances, even just a tiny amount of opiates can tip them over, and just removing the opiate from the equation can be enough to save that person's life. So it's absolutely essential that we have it. We sometimes receive some criticism around our drug-related deaths because we have such high rates, but we have this huge distribution of naloxone. But undoubtedly, if we did not have the level of naloxone provision that we do have, our drug-related deaths would be way higher. Just a note on treatment. So we have lots of moves towards improving our treatment services, but having worked in drug treatment before, there are significant issues in the way that we deliver our services. One of the major issues is that we don't have enough people accessing the treatment that they want or that they need. So around 40% of people experiencing drug problems are actually accessing treatment. So we have major changes in terms of our medication-assisted treatment standards that have been introduced just over the last couple of years that aim to improve access to treatment, so quick access so that people can get that treatment on the day that they present to services, that's equitable across the country, and that is absolutely, there is absolutely a choice. I'm conscious of time now. Can you just give me an indication of, am I over? Yeah, thought I would be. Sorry, I'm getting there. I shall skip over a few bits. And on top of that, we often have some quite punitive practice. So if, for instance, you are using additional drugs on top of your prescription, you will quite often be penalised for that. So people having either to be going back onto daily supervised prescriptions or having prescriptions reduced. We really need to get over ourselves. And urine samples has been mentioned a few times as if that's a defining factor on somebody's quality of life. Okay. A few reports there, not to mention, but just to say that there's been extensive inquiries into this. We know what we need to do, we just need to be getting on and doing it. The Drug Deaths Task Force was introduced in 2019, which had many areas of focus on the things that I've already discussed, which, none of those are things that were particularly new, but certainly helped to get a lot of things moving and get things being delivered. And one of the most significant things was an acceptance from the Scottish Government and the First Minister at the time that they had absolutely taken their eye off the ball in terms of drug deaths. So that was quite an emotional moment to hear that. And that has come with significant investment. So there's now a drugs policy division within Scottish Government, a minister that has that specific remit of drugs and alcohol policy, and a huge range of things that we're trying to deliver to reinforce the importance of harm reduction and also the importance of other measures as well, in terms of whatever service is right for that person is the service that that person wants at that time, or, rightly said earlier, they might not want a service at all. Which is also something that we need to consider. I'm getting right to the end now. Just want a brief mention of the National Collaborative. We're going to be talking more about this at the event tomorrow, but this is absolutely the essential part of making sure that voices of people with lived and living experience are part of that government mission. And it's not done tokenistically, so that people's voices are actually heard. There is a change team which will be putting together, helping to put together a charter of rights that will sit within the new Scottish human rights framework. So it will be enshrined in law, and therefore there will be accountability in terms of what's needed to be done. And just wanted to say that quality of life can only be determined by each individual. They can only decide how good their quality of life is. So surely we want to aim with everyone in terms of health, happiness, and there is no quality of life if you're dead. So the first priority has to be keeping people alive. And we need to be bold, brave, make substantial changes that will really change the outcome of people's lives. And we can't be looking back in years to come with regret about what we could have and should have done. Thank you.